counter, and Dr. Grover sir to please felicitate our chairpersons. Moving on to our next session, I would request our next chairpersons to kindly come on the stage. Dr. Vijay Arora sir, Dr. Mukesh Mehra sir, Dr. Ajay Kumar Gupta sir, and Dr. Aman Rohtagi sir.
So good evening friends. So our next topic will be insulin therapy in renal failure patients. We all know that we have to be very sensitive while treating the renal failure patients. So to take us through this topic, we have Dr. Hanish Gupta. So he's a consultant in Life Aid Clinic at Mayur Vihar and consultant at Sri Krishna Medical Center. And he has been honored with various awards and he has got mentions. And presently he is the executive member of RSSDI Delhi chapter also. So over to you, Dr. Hanish.
Thank you, Dr. Ajay. Thank you, all the respected chairpersons and the August gathering here from EDPA. And as the things have already been put in perspective, my topic is on insulin therapy in renal failure. But I'll give a little bit primer of what we stand as a world statement in diabetes today. This is a picture that I took in some conference. This is a picture of a cartoon from 1992. And this is about a story, seven blind men and the elephant. So out of the 7 blind men, one blind man just went ahead and grabbed the tail of the elephant and he said that this is probably some kind of a rope. And one went and grabbed the leg and said, no, this is not a rope, this is a tree trunk. And this is exactly what was happening in diabetes for many years. From 1920 when insulin was innovated, insulin was discovered. At that point of time, everybody was looking at diabetes from different angles. Somebody was saying it's the brain, it's the beta cell, it's the liver, it's the genes, it's the fat cell. Everybody was trying to, find out a way to just label diabetes as something for which they can find a solution. The therapeutic advances in diabetes have now given us more than 40 new treatment options in the very last decade. Starting from 2005, when we started getting DPP-4 inhibitors, in fact in 2000, we started getting DPP-4 inhibitors, we started getting SGLT2 inhibitors, we started getting GLP-1 receptor RAs. We started to have a cascade of things by which we could treat diabetes. But despite that availability of numerous treatments, diabetes still is the 9th major cause of death globally. It is leading to more than 50% people developing microvascular complications, 25% developing macrovascular complications. 1 out of 4 patients in diabetes is having CKD. In our country, maybe more so. Every second person in India who's getting a dialysis is a diabetic. You go to any dialysis center, you ask them whether you've got diabetes, they'll say, yes, we have. Every second person. But we all know that if you treat diabetes in the very first year and are able to bring down the HbA1c by a mere 1%, you can bring down the cardiovascular risk, the risk of myocardial infarction by 20% and the all-risk mortality by 19%. If you don't do that, the same risk, which was actually lessened and mitigated by 20%, will come back to 7%. And that's a very big loss because the risk which was mitigating earlier, it is not getting mitigated now. And the all-cause mortality, which was earlier being mitigated by 19%, is getting only mitigated by 3%. So very first year of diabetes, you don't mitigate, you don't lessen the HbA1c by a mere 1%, and this is what you get. This is metabolic memory. And everybody knows that despite the modern evidence-based therapy, people are still having heart attacks, people are still dying, People are still having problems with their eyesight. People are still having diabetic neuropathy. So why? You have done the best. You have got 40 new medicines in the pipeline, in the market, maybe 20, 30 more in the pipeline, and still your patients are not faring well. Diabetes, of course, we all know is a leading cause of kidney failure. More than 40% of patients with diabetes will develop CKD. And you can look at this graph, you look at the black rope, the black string, and you see that this is diabetes. Whereas you see the orange one, it is hypertension, and the purple one, which is glomerulonephritis. And many of us, when we see glomerulonephritis, we start fearing, ki ab to patient gaya. Now the patient is going to develop CKD. But so many years the patient is with us with diabetes, and we never look at him as a renal patient. We don't look at him as a cardiac patient. Whereas our view should be that the very first time that the patient is coming to us, he should be viewed as a renal patient, as a cardiac patient, as a patient who's going to have probably amputation because of peripheral neuropathy. And the moment we don't sensitize ourselves to that kind of a viewpoint, it's difficult for us to treat. Diabetic kidney disease shortens the lifespan by 16 years. This is a clear-cut message that comes after a study which was done in China by Wang et al. In 2017, when they did a survey on patients who were non-diabetic and diabetics. So if a clear-cut reason, if your patient comes and asks you that if I'm having diabetes, what are the chances that I'm going to have less number of years in my life, you're going to say, simply, there was a study which was done, and it clearly showed that 16 years are going to get lessened in your life. So the world is changing as we talk. We are changing from biochemistry to molecular biology to genetic science. We are changing from population to ethnicity to individual. We are no longer looking at spot blood glucose. We are also not looking at HbA1c. We are more looking towards, glycemic variability. We are looking at time in range. We are looking from drugs to therapies to precision medicine. We are looking from pharmacokinetics to pharmacogenomics. Now, what is that? See, looking ahead, type 1 diabetes and type 2 diabetes are not going to be labeled as only type 1 diabetes and type 2 diabetes. They are going to be endotypes of type 1 diabetes and type 2 diabetes. Already we know that patients who are in type 1 diabetes, because they are living longer, they start developing type 2 diabetes in the later years of their life. So you say type 2 diabetes overlapping on type 1 diabetes. So there is an overlap syndrome which is happening. If the patient who's been treated for type 1 diabetes for 30 years, he crosses the age group of 40 years, 40 to 45 years, he started developing features of type 2 diabetes also. So the patient who was not responding to insulin earlier starts to respond to OHAs as well. And then the reason behind it, the explanation that you give behind it is that earlier this patient was only a patient of type 1 diabetes. Now he has started developing features of type 2 diabetes, and that's why OHAs have started working for this patient as well. So that is T2 overlap on T1. And many patients who have got genome sequencing in their records, they are now going to be endotype specific, ancestry specific, lifestyle specific, and a new generation of therapeutics is going to come into our way, which is going to be emerging technology for an individual. This is pharmacogenomics, by the way. You choose an individual, you know the genomics of the individual, and then you ask the patient that whether the medicine that is being given to you, it is toxic, beneficial. If the drug is toxic but beneficial, you don't give. If the drug is toxic but not beneficial, there is no point in giving. Only the drug, when it is not toxic but beneficial, it will be given. And there is going to be a time that genetics is going to decide, artificial intelligence is going to decide what kind of drug you are actually going to give to the patient based on the genomic sequence of the patient. And already the GWAS program is going on in US, which is Genome-Wide Association program, in which every individual can go and they can give their blood sample, give a simple signature, and then their genome is going to be sequenced, and their entire ethnicity, their entire ancestry is going to get labeled as per the requirement. As for the future, our task is not to foresee it, but just to enable it. Weight regulation is not a separate program from diabetes management, and personalized precision medicine for obesity and type 2 diabetes is now becoming a reality. So you have got GLP and GIPs which are working for some patients. You are having GLP-1 and glucagon which is working for some patients. You have got GLP-1 and dexamethasone. Now this is very strange. Dexamethasone for diabetes. You are giving dexamethasone as a therapy for diabetes. Why you are giving it? You are giving it because in the very early years you know that it is autoimmune diabetes. Because of the autoimmunity, the beta cells of Langerhans are undergoing apoptosis. If you know beforehand by the genetics of an individual that some kind of individuals are going to have some kind of apoptosis of the beta cell of Langerhans purely because it is going to be autoimmune phenomenon, you give dexamethasone and the patient is going to get better in diabetes. Now that's the beauty of it, that beforehand we are going to come to know about the sequences because of which diabetes is going to happen to an individual. And if we are going to enter into a phase in which diabetes is going to be not reverted but averted, we are talking about diabetes reversal programs. This is diabetes aversal program. Diabetes is not going to happen because you identified the individual's genetic sequence and you came to understand that it is autoimmune type diabetes that is going to happen to this individual in years to come. Let's give him GLP-1 and dexamethasone and he is going to respond wonderfully. And this is also happening with patients who are having hypothyroidism, and hypothyroidism, because of the nature of hormonal imbalances, patients are having some kind of a cascade events that is leading to diabetes. You give them glucagon and T3 and these patients revert, not revert but avert. They don't develop diabetes in the times to come. And tripeptide, we all know that nowadays is the time when we are talking about GLP-1 receptor analogs, GIP-1 receptor analogs, and also glucagon agonists. So all of these three together have the propensity, have the capacity to bring down the weight of an individual by 25 kgs to 22 to 25 kgs in a matter of just 3 to 6 months. So now you can run the slides. After this little primer that I wanted to give about the situation and the presence and the standing of diabetes today, this is not my slide. I'd like to take another just 10 more minutes for insulin therapy in diabetes, which I believe that everybody already understands quite nicely, but just as a refresher, we are going to take it up. Yeah, thanks. Can I run it from my end? No? I can? Thank you. So this is the treatment of diabetes. Diabetes and CKD, why it is a double whammy. We know that when there is diabetes, there is more hypoglycemia. We also know that there are more incidences of severe hypoglycemia. These are the KidGo guidelines. When you look at a patient of diabetes, you are not just looking at one aspect of diabetes. You are not just looking at HbA1cs. You are also looking at how bad the kidney is. You also want to know that whether the other macrovascular complications are taking the toll on the patient. What are the comorbidities by which the patient is getting affected? What is the life expectancy? The patient is already going to have a very short life expectancy. We all know when the kidneys have already gone bad. And hypoglycemia awareness, whether it exists or not, many patients come to us, they have got sugars less than 60, 50, they don't even know about it. Sometimes the patients are being assisted because they are having loss of consciousness. They never told any of their attendants that what is exactly happening to it. The resources for hypoglycemia management are also very scarce in many of the countries, especially in a scarce country like us. We do not have push notifications for our patients. We do not have 911 in our country. We do not have any kind of a push button by which patients are going to be immediately being attended by paramedical staff. And the propensity of the treatment to cause hypoglycemia is also very important. Unmindfully, many of us are prescribing sulfonylureas to our patients, not realizing that the half-life of sulfonylurea is much worse than the half-life of insulin. So why not insulin in patients of diabetes? This is the kidney heart risk management factorial that has been given by KidGo. SGLT2 inhibitors, of course, top of the chart, because not only they are having an effect on the glycemic control of diabetes, but they are also having an effect on the trajectory, on the progression of diabetes. And that's why so many studies after EMPA kidney study, we know that not only in patients of diabetes, SGLT2 inhibitors as a class of medicines are also effective in other ailments of kidneys as well. And RAS inhibition, we all know, it's very much required. Statins, glucagon-like peptides, non-steroidal, mineralocorticoid receptor agonist, the new entry finerenone into this picture, forming another pillar of support after RAS inhibition, after glycemic control. Non-steroidal and SGLT2 inhibitors, non-steroidal MRAs are also a very important effective tool that we have in our armamentarium. But of course, we want to use them only in patients who have got albuminuria. Just don't be guided by serum creatinine for non-steroidal mineralocorticoid receptor analogs. Look at albuminuria as well, and that's why the importance and the emphasis of getting a urine ACR for our patients done cannot be overemphasized. Sometimes we get a lot of, we get happy with whether when we see that the creatinine of the patient is fine, and we do not want to change that creatinine to eGFR values. Though there has been a paradigm shift in the laboratories also, now they have started giving eGFR values also for the patients. Though I don't understand that how do they get to know it, because they never ask the weight of the patient, they never ask many of the questions that are required for the formula, but then they give eGFRs. Where having a simple formula on our phone is probably a better mechanism. So two very important tests that we should never let our patients ever go away from is actually serum creatinine translated into eGFR, and secondly urine ACR. If these two tests are done, I think so as physicians we have done our job and we can take things forward from there. KIDGO also talks about the therapies in addition to SGLT2 inhibitors to choose from. They talk about GLP-1 receptor analogs, DPP-4 inhibitors, insulin, sulfonylureas, probably in that particular manner. Insulin still exists, it's still there, it's very natural, it can be used. One very important question that keeps on popping in everybody's mind is that do we use insulin and in its conventional form, or do we use analogs? Well, there is nothing against analogs. Let us clear that. So if you are using basal insulin or if you are using rapid acting insulin, whichever kind of insulins you are using, probably you will have to bring down the dose of the insulin, but analogs are nowhere not prescribed. Analogs will be prescribed, should be prescribed, can be prescribed. And evidence with insulin analogs is absolutely wonderful. If you compare them with the baseline, they bring down the HbA1c better than the NPH, and the number of nocturnal hypoglycemia episodes that a person encounters with insulin analogs is much lesser than the conventional insulin, especially NPH. Insulin glargine in type 2 diabetes also, it's changing in glycemic parameters, it is changing HbA1c. But the important thing is that the number of hypoglycemic episodes is reduced. Some people think 1 episode, 2 episodes of hypoglycemia, it's a training for the patients. What's the loss in that? Well, that episode can be a stroke, episode can turn into a nightmare because of the LOC getting continued over the night. That episode can turn into some kind of an injury to the patient. Imagine a patient having a hypoglycemic attack in the bathroom and hitting the head, having a head injury. So hypoglycemic episodes should not be only construed as episodes in which sugar has gone down. Look at them as an episode of a potential injury to the patient. Injury to the brain, injury to what? Myocardial infarctions also, by the way. If you have got many episodes of hypoglycemia, chances of myocardial infarctions also increase. This is the efficacy and safety of insulin glargine. I don't want to go into it because the conclusion is very simple. Insulin glargine has improved HbA1c and has been safe and well tolerated for patients with diabetic nephropathy. And in overt nephropathy, type 2 diabetes, Lispro also prevents glomerular hyperfiltration, offsets the renal effects of meal and meal-associated mechanisms of hyperglycemia. Now, if you have a patient, this is an elderly patient, very intelligently chosen by the people who have made these slides, 63-year-old man, 80 kgs, BMI 27, type 2 diabetes for 16 years, on linagliptin, glimepiride, metformin, glycemic control gone haywire, now starting to have an eGFR of 31. This patient comes to you for the first time in life, being treated by some other doctor. Your job would be to think about the fact that if you are going to leave this patient on a glimepiride dose, the chances of hypoglycemia are going to be super high. And that's why to get the glycemia under control, we have to make the patient first of all safe. Leaving the patient on a glimepiride dose of even 2 mg is a catastrophic scenario because the eGFR has gone super low. It is 31. So in dosing and titration of insulin in CKD, if the eGFR is less than 30, you do give multiple doses of rapid acting insulin analogues, and in such situations avoid basal insulin. Don't give basal insulin. Go from meal to meal. Teach the patient. Ask your diabetes nurse to teach the patient. It's important because empowering the patient. Doctors can't be everywhere. Ultimately, it's all about empowerment. If you are not empowering your patient, you are doing something which is going to cost you later. If we are going to teach the patient what needs to be done, if we tell them that the ball is in your court, take it from here, I'm going to teach you everything and you should understand the logic while I'm doing this, believe me, your patient is going to listen to you, the patient is going to abide by you. If the eGFR is above 30 to 30 and hovering somewhere above 30, we can say just above 30, at that point of time, 2-3 injections of insulin analogues along with basal insulin are recommended. But don't give basal insulin if the patient is having an eGFR below 30. It's again venturing into a difficult terrain. So this is the case management. They started with the patient and they stopped glimepiride and metformin, the right thing to do. Some scientific houses say that if the metformin is being there on the patient's prescription, just keep on continuing it. But they are silent about eGFR below 30 again. So many say that, okay, if the patient is entering into a stage of CKD3 or CKD4, probably that's the time that metformin should be thought about. But if patient is already taking metformin, might as well just continue it. But then again, they are also silent about a situation when eGFR has already gone below 30. So please, if eGFR has gone below 30, I think it's recommended that metformin and of course sulfonylureas are of course off the charts, but metformin should also be given a thoughtful process. SGLT2 inhibitors will not be considered. Like I said, the people who made these slides are very intelligent. They made fever and UTI already a part of it. Otherwise, of course, SGLT2 inhibitor could have been there. And insulin was initiated. And they started with a basal bolus, with basal being very less. And another thing is that some of the better insulin analogues which are available, they have got half unit dosing also. Sometimes these half unit dosing are very good for patients, especially who are renally compromised. How many of us have actually used it, it's a question of survey, but yes, many of the colleagues that I have heard, they say that half unit dosing is also recommended for some of the patients as a titration. With that, I would just like to conclude that we should not forget that insulin therapy for glycemic control in patients with diabetes and renal problems is something that we all should be accommodated to, all should be comfortable with, and insulin type dose administration should be tailored. Don't use basal insulin in patients who have got eGFR very low. Use basal bolus only for patients whose GFR is more than 30. Give multiple dose injections, empower your patients, always tell them, bring them on the table and discuss with them that what are their possibilities. In that regard, insulin lispro in type 2 diabetes in nephropathy, it does prevent glomerular hyperfiltration and reduction in renal effects and meal-associated hyperglycemia. And higher is the patient's stage of CKD, more are the chances of hypoglycemia, and that should always be on our consideration. Thank you so much.
Thank you, Dr. Hanish, for excellent presentation. I think you very comprehensively covered almost all aspects actually, starting right from the fundamentals of diabetic kidney disease and then management part, and the importance of insulin analogs actually, and the risk associated with the actually increased risk of hypoglycemia. So you have to be very, very actually, I think careful while managing diabetic kidney disease, risk of hypoglycemia, correct choice of the therapy, whether even if you have to give multiple injections, I think this should be preferred. And basal actually use has to be very, very cautious. And regarding the severity of the diabetes associated diseases and especially kidney is very, very high. You have said the more than 40% of the diabetic patients develop kidney disease. So I think it's a very, very important, I think the insulin therapy and especially analogs. So any questions from audience or any comments from?
Yes, sir.
While using premix insulin in these patients?
So, sir, premixes, they don't give us flexibility of use because premixes are coming already in a set pattern, 25-75 or 30-70. And in that 70% insulin is already long-acting insulin. And these patients probably they are living meal to meal. Sometimes they don't eat better, sometimes they are skipping their meals, sometimes they are having nausea and vomiting, which is associated with the entire carbohydrate load getting vomited out. So it's better always to go for plain insulins, conventional insulins, or Lispro type analogs for the management.
No, the reason that I ask is because, if you give prandial insulins, you have to give 3 to 4 injections before every meal. Most of the patients deny that or, not willing for that. So in that case, and basal is something that we want to avoid. So
Sir, that's a very good question, and that's a real world scenario and a very, very practical situation. In this kind of situation, what we do is that we do not ask the patient to take multiple dose injections. We just ask them that please tell us what is the, which are the 2 large meals that you are taking. Because most of these patients, they are not taking 3 or 4 meals in a day. They are not, so if they are able to tell us, okay, this is the 2 large meals that I am taking, we try to keep our insulin dosage at that particular time only, so that we can at least cover that prandial part. And of course, if the patient is having a eGFR more than 30, then of course basal insulin is also there, which is constitutionally covering the control of glucose over the day.
Thank you.
Thank you, Anish. Ravinder ने मेरा question चुरा लिया. This was the question I was asking. So thank you for a wonderful talk. And this session is now. Yes.
Dr. Hanish, I think it's a very wonderful talk, and you have covered, as Dr. Mehra said, all the aspects of insulin in CKD. Right, we all know that in CKD now the GLP-1 receptor agonist is a part, right? So suppose the patient requires insulin, we possibly start basal insulin at the very core, because sometimes Dr. Mukesh said sometimes basal bolus sometimes not feasible for them, right? So now we have the combination therapy is also available for GLP-1 with basal insulin. So how you rate this combination therapy in patient in CKD?
So there is one combination that we have, which is Iglar-Lixi, which is Soliqua, which has come from the house of Sanofi. It is a combination which has got, in that combination for every unit of glargine, we are providing 0.5 unit of lixinoside. Problem is that GLP-1 receptor analogs, they actually increase nausea and vomiting on a much higher propensity in CKD patients, because they are already having uremia, and uremic gastritis is there, and these patients, they are already having they are very low on appetite. They're already very low on appetite. If they're so much low on appetite, and on top of that we add some kind of a GLP-1 receptor analog, then their appetite, further gets mitigated. In that kind of a situation, we don't want to we don't want to get pushed against the wall that the patient stops eating altogether. The intake goes very bad. So I would try to peg the use of these kinds of molecules, especially our Iglar-Lixi, which is Soliqua, to a eGFR level of more than 60. I would not like to use them below 60.
Dr. Anish, so according to you, then in patient of CKD, we should not use GLP-1 RA?
No, sir, that's not what I am saying. I am saying that the patients of CKD who have already developed uremic gastritis, who are already having nausea, vomiting, who have already lost their appetite, who are already losing weight, those kinds of patients should be spared from use of GLP, because we have got a very good armamentarium of drugs already available.
Yes.
We don't have to fit the drug accordingly to the patient.
Dr. Hanish, I have only one comment to make regarding that Iglar-Lixi. See, in a patient of CKD, on one hand we even try to adjust half unit of insulin. On the other hand, with half unit of insulin, we are giving a funny dose of lixinoside. I don't think makes any sense. Yes. In a patient of CKD, let us be very honest.
Yes.
Let us give basal insulin and give a small bolus as per his major meal. And this product to me looks very funny for a CKD patient, if you agree.
I agree with you, sir. Always.
Thank you, Anish. Thank you very much. And we close this session and hand it over to organizers. Thank you very much.